Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with my favorite ICU doc. How are you doing today, Doug?
I am awesome. The streets are brined, and we are ready for Snowmageddon here in central North Carolina.
I know. It's like all the way down to 28 degrees outside, so everybody's bracing for it.
Exactly. There's not a jug of milk or what is it? What is the other thing? Oh, or a loaf of bread to be had.
Yep. All the water, all the bread, all the milk,
gone.
All the eggs are gone.
We're
obviously ready. So, other than the snow, what I did want to talk to you about today was acute liver injury. And the reason why I bring it up, it came up in the podcast on zombie blood, hypoxic hepatitis, shock liver. And I've seen it a couple times in other Instagram posts and other posts as a thing associated with shock. So this is a complete blindside. I had no idea about it. So I thought I would talk to you. What the hell is acute liver injury, shock liver, etc.?
Awesome. Well, little did you know that the liver is one of my favorite organ systems, and that for a while it looked like my career was going to take me out of the Army and into a liver transplant intensive care unit. Which I spent a month rotating in when I was a fellow. So got a lot of exposure to how the liver can be injured and ways to diagnose it, and most of which are only available in a hospital setting, but enough of which could be available either in a prolonged field care or a Role 1 setting that it's worth talking about them, to include them in your vigilance, and then the ways to support it. So happy to talk about it.
Well, I guess first let's do just a basic, like, other than, physical damage to the liver, like, what is acute liver injury?
Perfect. Can I table that question and just kind of do a once over the world of actually what the liver does?
Sure.
Because I think it's nice to have that in context for both diagnosing and understanding, the functions of the liver. Is an amazing organ. It obviously plays a role in toxin and drug clearance. I think everybody knows that. But what is less known is that a lot of blood metabolism, a lot of the organ system of the blood actually depends on the liver, actually for direct production. So every clotting factor that's in the bloodstream is produced in the liver. And then certain synthetic stimulants, I think about the stimulus needed to produce platelets, is actually sent from the liver to the bone marrow. And finally, the liver scavenges iron from dying, aging red blood cells to reuse to make new red blood cells. So oxygen, hemoglobin oxygenation and coagulation are both intimately dependent on a functioning liver. And as we'll get to, one of the signs that the liver isn't doing so well is when coagulation is impaired and you have an unexplained anemia. The liver also produces bile, which is essential for digestion. And really importantly, the liver converts unused glucose. So, you eat a big meal, your body says, hey man, I only need like 20% of the glucose that was in that meal. The other 80% is converted to glycogen by the liver and stored in the liver. And then it can be reconverted back into glucose in times of when you're not feeding. So in between meals, or let's say you're a patient and you're NPO or you're not being fed, the liver is a rich synthetic source of glucose, which is of course essential for brain function, as well as a bunch of other bodily functions. And then I guess finally, one of the things that the liver does that's super important is it converts ammonia, which is very toxic to urea for excretion. And if that doesn't happen, unchecked rising levels of ammonia can first cause confusion, then lethargy, then coma, and then cerebral edema and death. So, one of the things in acute liver failure that's really severe that we check for is neurologic status. And if we don't have a good neurologic status, go to the CAT scan and look for signs of cerebral edema. So that's kind of a once over the world about what the liver does and sort of the so what if the liver is severely injured. The ways it can be injured, the most common that we'll see in tactical medicine will be either a hypoxic injury from lack of perfusing blood flow. And I think that's what your podcast that you referenced was talking about with hypoxic hepatitis. It can be injured, very commonly injured in heat stroke, in severe heat injury. The liver does not like hyperthermia. And I've seen many terrible cases, some fatal of heat stroke where, the liver was profoundly injured, never recovered. And that was kind of the tipping point between survival and not survival. And then lastly, toxins. The most famous toxin injury to the liver is good old Tylenol, acetaminophen. And in high enough quantities, we saw a fair few, both willful and deliberate and accidental Tylenol overdoses in our liver transplant unit. So that's kind of an overview of what the liver does and how it could be injured.
Okay. So, I mean, it's a wide variety, especially if you're talking, I think, hyperthermia. I would be more worried about cooling this guy down. To be honest, I would not think about the liver probably at any point. So how would I even recognize, obviously labs come to mind, and I think it's AST, and I think there's another one, that spike. But to be honest, I'm not super confident that that's part of my iStat cartridges, to even clue me in that that's a thing. So what's your first tip off? I think there's something wrong with this guy's liver. Let me get the labs to find out.
The two easy labs that will be disordered are glucose will be low. So you can use a point of care glucometer, and you'll check your patient and the glucose will be 40, and you'll give them some dextrose, you'll give them some sugar, and you'll check it in an hour and it'll be 50. And then lactate will be elevated because one of the toxins in the body that the liver clears is lactic acid. And so when liver metabolism is impaired, you got all this excess lactate sitting around. And a lot of times people will, even after you resuscitate them, will have their blood pressure is good enough. All the other signs of hemodynamic stability are good enough. And then you've got this lactate of, 6, 8, 10. And then you have to sort of put it in context. Could this be a liver injury?
Right. So, I mean, is this kind of a death sentence? My first thought would there's a problem with hemodynamics. He needs blood. We need to get oxygen. We need to get perfusion to that liver. How on earth would I even begin to start walking this back? I mean,
basically, you support the liver as an organ system the way you support all other organ systems in shock, right? You treat the cause. So, if it's hemorrhagic shock, get the bleeding under control as best as possible, ideally, definitively, if not as best as possible, and then you resuscitate with the appropriate resuscitation, which in this case is going to be whole blood. Whole blood in the setting of acute liver injury and the coagulopathy that happens as a result of that is super useful because you've got the richest concentration of clotting factors, platelets, and fibrinogen in whole blood than in 4-factor blood where it's more diluted by citrate. I should say another concerning sign of acute liver injury is coagulopathy, right? So you're resuscitating this guy, your patient, and he's still bleeding, especially bleeding from things that shouldn't be bleeding, like IV sticks or blood in the Foley catheter. That's got to raise your level of suspicion.
Yeah. Like any kind of cut small things in the mouth, nosebleeds, any things like that?
Your Crike site, any place you did an intervention. Exactly. So glucose, lactate, and bleeding are really the three things that you have in the field that can diagnose this. And then labs, if you want to talk about them, we can talk about them just for awareness, but most of those are higher level.
So, I kind of assumed that really the only thing you can do, try to maintain perfusion, roll back whatever the cause was the best as possible. If he was hyperthermic, try to make him euthermic, the best you possibly can. That seems like the logical thing to do. I guess what I don't really understand is you have a liver that's failing, coagulopathies are going crazy. He's not creating any proteins. Like, there's lots of things that are falling apart. How do I do the obvious to maintain this organ system while simultaneously it's desperately trying to screw everything up?
It's a tough thing because really when the liver goes to that level of dysfunction, and the term that we use in hospital and in critical care is something called synthetic dysfunction. So the liver is injured badly enough that it can't make the things it's supposed to make, right? It can't make cytokines to modulate inflammation and infection. It can't make, I didn't really mention those as one of the things the liver does, but that is another thing it does. It's super important. It can't make clotting factors to clot the blood. It can't, convert glycogen to glucose. And so if there's acute liver injury is bad, that's, your liver enzymes, your alanine aminotransferase, which is ALT, or aspartate aminotransferase, which is AST. Those are called transaminases, and those are released when hepatocytes or liver cells themselves are damaged. They're elevated. Your coagulation parameters, your international normalized ratio is elevated, and your lactate's elevated. So it's one thing if just the liver enzymes are elevated, that's a injury. If the other things that the liver makes, represented by glucose, lactic acid, coagulation labs, those are abnormal. That's acute liver injury with synthetic dysfunction, which is worse. And honestly, it's, you do your best, you correct all the things you can correct, you support all the things you support, and then it's really, between your patient and a higher power to see if they pull through. And some do and some don't.
Obviously, hemodynamics makes perfect sense. I got it. All your drugs are going to be metabolized different, or they won't be metabolized. They'll just continue floating around.
A bunch of them, right. Which means it's going to take them longer to get to work, and they're going to stick around longer.
Right. If I think, correct me if I'm wrong, I think if you stick with knowing what your actual goal is, not just I give 50 micrograms every X number of minutes. If you at least stick with what your goal is, you'll probably avoid overdoing it. And just understand it's going to take longer to set in. You're going to have some patience to watch till this thing sets up. Glucose, I imagine you're just doing serial glucose checks, getting small bumps to try to replace glucose used, since it's not going to be converted from glycogen back to glucose.
Most of these patients, once it's established that they're at that level of liver dysfunction, will be on a pretty concentrated dextrose drip, like D20. There's D5 is common, D10, but most of them are going to be on a D20 drip. If you can at a not trivial rate, like 50 mLs an hour or so, just to maintain adequate, 70, 80, 90 finger-stick glucose.
Okay. Does that seem, from somebody who has zero idea what to do, does that seem somewhat reasonable?
Yeah. One of the important things with hyperthermic liver injury is keep checking a core temperature, because, you can have their surface temperature cooled, everything can be looking good, and they're still cooking inside. A lot of times hyperthermia sets up to the point where they're warmer on the inside than the outside. So at least check a rectal temperature and check it frequently. And you will be surprised at how you might get a surface temperature of 100, which is getting, close to normal, or 99, which is getting close to normal. And, your rectal temperature will be like 102, 103. And as long as it's elevated, it's doing damage. And the more damage it does, the harder it is to recover.
Okay. Like how long in the ICU, you mentioned that you see this, hopefully not super frequently, but I'm sure you see it. Like how long does this pathology take? I mean, obviously it depends on what is the cause, but is this something you see within the hour? Do you see this in 6 to 12 to 24 to 48?
Great question. Because of the resilience of the liver, because it is a very resilient organ, it will take a lot of damage before it starts to show signs of synthetic dysfunction and even injury to your hepatocytes, even a rise in the levels. And so it is a later sign. Typically, we would see signs of kidney injury before we see signs of liver injury. Kidney injury within the first couple to several hours of a big insult. Liver stuff, it's not uncommon for it to show up like the next day. It's one of the reasons that and I keep going back to heat stroke because that's really where I've seen like kind of the worst liver pathology. Although we see it in cardiac patients as well, in my current job. But, we talk about like the tail of acute liver injury, that it takes a while to set up. And then it takes a while to resolve, so onset, hour 12 to hour 24 and, peaking, potentially hour 72, before it gets better. And it's one of the reasons we watch heat stroke patients, especially, really high temperatures and with mental status changes and kidney changes. We will admit them always and push to keep them at least 2 days. Because it would not be uncommon to send somebody home from the emergency room when, after some hours and the kidney function is getting better, and then have them go home and have the liver decompensate and potentially die.
Right. And I imagine, because that would be super tempting, Joe comes in way too hot. Somebody picked him up off the side of the road to get him cooled off. We give him some fluids. Everything's going well. He's annoying everybody here, let's get him out of here. Say that was the case. Like, what would you tell, this person, like, what should they look for in order to come back other than like your urine area output?
Well, I wouldn't send them home.
Oh, okay.
If they're in the military, I get to tell them they can't go home and tell their leadership they can't go home.
That's true.
So, I've just seen too much of this and, stationed where I was. And as we get our fair share of heat exposure and heat injuries. I just wouldn't, I would watch them for 48 hours. Minimum of 24. If their liver function is rock solid stable, absolutely not a blip on their liver function lab tests at 24 hours. And, they weren't hyperthermic for that long, and if all the stars lined up, I might send them home at 24 hours. But if anything was, at all headed toward the AST and the ALT are in the hundreds, normal is like, 30s and 40s, right? And in severe injury, they get into thousands. So if I see them trending upward and I'm checking in probably every 6 hours, they're not going home until they go down.
Okay.
Full stop.
Okay. So
sorry for Sergeant, but
no, well, he's got to pick up rocks, right?
Next time, have him pick up rocks with a gallon of electrolyte solution.
Now, this also kind of leads me to wonder, like, why does nobody ever tell us anything about this? Like, this seems like a fairly common, hopefully not common, but not unheard of problem of acute liver injury from very common injuries that we see. But at no point in time does anybody even mention that this is a thing. So, like, part of me feels cheated, and, blissfully unaware that this was even a thing. So is there things that I can do other than resuscitating faster? Is there anything that you can do to prevent this?
Right. With shock, let's go to, because heat injury is generally preventable. So we're going to leave that off the table. Let me come back at some point, though, to the role of physical fitness supplements in your risk for heat injury. We don't have to cover it now, but let's not close out the podcast without talking about that. So shock, honestly, acute liver injury is really a function of something you've probably heard talked about called the shock dose. So the magnitude of the shock, whether that's, a really bad septic shock with a multi-drug resistant organism with virulence factors, none of which you're going to know, but, that's how they behave, or bad malaria, which of course is taking up roost in the liver. So that's, that's a horse of its own color. But in traumatic shock, bad, multi-polytrauma, bad polytrauma, a lot of blood loss, potentially a longer time to stabilization of bleeding and onset of resuscitation. So the longer that you're unstable, the higher the shock dose. So it's either the magnitude of the initial shock dose or the length of time in significant shock to begin resuscitation, or both. That's where you get into trouble with the liver. Because like I said, other organ systems are going to get affected first by low perfusion than the liver. The kidneys, quite famously, the upper levels of the brain in terms of mental status changes quite famously. The kidney, skin, in terms of modeling and coolness, et cetera, cyanosis, even the GI tract, with malabsorption, all of those are going to show signs of organ failure before the liver will. So it's really a significant shock. And at a certain point in a prolonged field care setting, in a combat setting, the onset of acute liver injury, severe acute liver injury with synthetic dysfunction, may be a deciding factor for how you retriage that patient. Because they're going to consume a lot of resources just to stabilize them. You're going to have your resuscitation spot on. You can't let the blood pressure drop, mean arterial pressure drop below 65. I know I'm not a numbers guy, but that's one, I would feel very bad about letting somebody with bad liver injury run on the low side of blood pressure. You can't let them get hot, even a half, a degree, really very labor and resource intensive. Sorry, not to be grim.
No, but it's super realistic because I guess what I was thinking, I've put all of this effort, I've given everything I possibly can, and now this thing is happening. And I could easily see just the human thing of like, we got to keep going. And it's a long, slow process. So it's not, the lights are out and it's over. It's hours, maybe days, before, the dominoes finally fall. So I could easily see just more and more and more resources, because each time it's an increment,
Yeah, they're going to be resource intensive, and they're going to be people resource intensive, because you've really got to be monitoring them super closely, vitals, on the clock, charting on the clock, trend analysis on the clock. You can't really take your eye off of them. But, and I don't know why you haven't been told about it, but, that's why you have me on, is to look under the rocks of critical care and expose the.
Yeah. I mean, obviously you've heard of, gunshots to the box. Yes, definitely. I've heard that. But as far as acute liver failure, I've heard the term, but beyond that, never. But earlier you mentioned you wanted to talk about supplements. I need my creatine to keep my gains. So,
the issue with a lot of these supplements is they contain some form of stimulants that increase metabolism and that need to be cleared by the liver, or that are cleared by the liver. And in heat injury, we've seen time and time again, the cases are more serious when they're substances with, a laundry list of ingredients, none of which are really they're of uncertain manufacturing origin, and certainly uncertain regulatory approval, the risk of heat injury goes up, and the risk of severe heat injury goes up, and the risk of multi-organ failure and death goes up. And so, you want to talk about preventable, the ways to prevent serious liver injury. Don't go smoke yourself in the sun when you've, taken a bunch of scoops of something that has a bunch of laundry list of ingredients that you don't understand.
Right. I mean, are there supplements that come to mind that are more dangerous than others?
I am far enough out of the operational world, operational surgeon, that I don't know what the list is. When I was, active duty, we definitely had, kind of our list. I think the, command surgeons are probably a good source to go to, in Army, like the group level, or, equivalent level in the Navy and Marines and Air Force. I think there are probably, because these things change, right? Things come in and out of flavor as people make them popular through whatever social media or other influencers. And a lot of times too, manufacturing companies will change labels. Just when they start to get a bad rap, they'll keep the same ingredients and put a new label on it. And then they're like, oh, it's something new. And it's not really. So I would go to a trusted DoD source for, what the things to avoid are.
Awesome. As far as acute liver injury, is there anything else that we're missing?
I don't think so. The liver is, like I said, it's remarkably resilient. It can withstand a lot of insult, hypoxia, heat, toxins, and recover. There is a role for liver transplantation in acute liver injury, but I'm not familiar. I've been out of that world enough that I'm not familiar with what it is. But I think especially with toxin ingestion, right? So especially with like a Tylenol overdose, of whatever deliberateness, and many of them are accidental. One of the worst cases I saw in fellowship was somebody was taking Tylenol, and I think it was a muscle relaxant. It might have been Flexeril, and didn't realize that the two sort of were both cleared by the same enzyme in the liver, and it was sort of like double the effect. And, they were in a lot of pain, and they were doubling down in their dosing. And the next thing you know, they came in fulminant liver failure. Drug overdoses are a very common source of referral to liver transplant.
Oh, yeah. I have no doubt. I mean, God forbid you drink a glass of grapefruit juice. You're done.
I'm less familiar usually with other mechanisms, right? Hypoxia due to shock, thermal due to heat. The patients are just so unstable that they don't make good transplant candidates. So, and unfortunately I think there are some experimental sort of extracorporeal liver machines, like dialysis for the liver, but if they're out there, they're very rare. They're only at university centers, and it's not like, you knock off your kidneys and you go on dialysis until you get a transplant. Liver, you pretty much generally need to sustain them. I think some of the transplant centers actually do have extracorporeal circuits, but again, we're getting into esoterica here. For our purposes of our conversation, is really do your best with resuscitation and treating the source, stopping the bleeding, getting the temperature down, doing a really good resuscitation, being super vigilant, and that's all you can do.
Yeah. It also brings to mind like the concept of, damage control resuscitation. A lot of medics, and even myself included sometimes, is I just need to get them enough, right, to keep, a pulse, to keep okay blood pressure, but they're not like fully resuscitating this guy. Like they're not getting great urine outputs. They're going more by pulses and hopefully a blood pressure and a lot of gestalt, I think. I don't think they necessarily realize it wasn't meant to be like that for that long, So when, I guess, maybe a final thought, when, say, surgery is not a thing, when should I be transitioning from that, permissive hypotension into an actual get them fully resuscitated to hopefully to avoid this acute liver injury?
I thought you were going to ask me the easy question, which is when do I do it if they have an acute liver injury? And the answer is like right away, because optimizing perfusion is really one of the few things you could do. And it doesn't have to be a lot. And again, here's where I really like mean arterial pressure, right? Because you can have some systolic and diastolic blood pressures that don't look all that good, but your mean arterial pressure is pretty good. I mean, do the math, play around with it on an app on your phone, but like 90/50 is I think off the top of my head, should be a perfectly good, blood pressure for a perfusing mean arterial pressure. So I always harp on mean arterial pressure because that's sort of the driving pressure that the organs see. They don't see systolic around, 24/7. They don't see diastolic 24/7. They see the mean. So that's their level. To prevent it, it's a great question. It's a great question. I guess, how permissive is your hypotension and how bad is your organ failure? I mean, if they are anuric, if they're not making urine, I would say that's your first resuscitation goal, right? Get them to a reasonable physiologic mean arterial pressure and see how the kidneys respond. And people can be anuric and not have a liver injury, at least 9 times out of 10, maybe more.
Easily. Yeah. It's not hard at all to not make urine.
Especially if you're fully split.
Right. So here's another thing, and feel free to say I'm full of crap. I'm starting to get to a point where, people throw numbers, systolic of 100, systolic of 110, even I think MAP of 65. I'm not sure that they always remember that there are such things as hypertensive people walking the earth, and they live normally at, a systolic of 150 or 160, and you may reach these numbers and they're still not resuscitated, thus the need to monitor urine output, to look at their skin temperature, to skin color, etc.
The most
Go ahead, let me have it.
Common scenario where you have somebody with chronic severe uncontrolled hypertension. So I'm talking like systolic blood pressures in like the 180 to 200 range. And they drop. They drop because they're injured. They drop because they're septic. They drop because you take them to the OR and do surgery, and you bring their systolic down to 100. The most common symptom of that is they're going to stroke. They're going to stroke because you have taken their cerebral perfusion out of its zone of autoregulation, which is good. Like, there's a pretty wide high and low pressure that the brain will tolerate. So if you're like 180 here in the middle, it'll probably tolerate 220, 230 up here, on my right hand, and it'll probably tolerate, 150 on my left hand. So normally for us, right, if we're 120, right, here in the middle, we're going to be fine up into the 160s, and we're going to be fine down into the, 80s systolic. And that's why people with well-controlled blood pressure, don't stroke out when their blood pressure is 80, and they don't stroke out when their blood pressure is 160. Other organs do have autoregulation, and so it is a thing. But, in a DOD audience and a military audience, I would hope that those aren't our patients that we're dealing with, and that we're just trying to get them to a normal physiologic perfusion pressure.
No, it makes absolute sense. But I definitely have seen my fair share of team sergeants and warrant officers that do, run hot when it comes to their blood pressure. Controlled. They're fully fine. They're fully cleared. But it always makes me wonder, just resuscitating to a goal, a number, kind of meant to be general for everybody, if that's really good enough, or can I squeak out a few more wins?
It's a good question. I mean, it's funny because I deal with a fair few super hypertensive people in cardiovascular critical care, typically in the setting of dissecting their aorta because of the blood pressure. And we don't generally resuscitate them to a higher blood pressure than usual. Our resuscitation goals in them is pretty similar to what it is in everybody else. Part of that is, they've got a dissected aorta. We don't want it. We want to minimize pressure to let the repair heal. But I don't know. It's a good question. I'll have to look up, I honestly, I can't quote you the zones of autoregulation for every organ system. The brain, I think I'm pretty familiar with, but I don't know them off the top of the head.
No, that's okay. I'm just wondering, is my thought process that far off?
In the setting of stroke, no. In the setting of, you lost your neuro exam, they've got, one-sided weakness or something else, and they were running super high, then yeah, you really probably want to push them. And you may even want to give them pressors to get them up there. You may want to run an epi drip to get them back up to, not where they were before. So not like 200, but like 160. And we do that with stroke. In neurocritical care, we do that. If, our buddy David, our favorite neurointensivist, is listening and wants to chime in. I don't think I'm talking out of my hat on this one, but other organ systems, very selective. I mean, it's not usual practice. It's not usual practice to try to get the kidneys to work by pushing the blood pressure, or the liver to heal by pushing blood pressure in someone who's hypertensive.
Okay. I guess I'm not thinking I purposely push them to 160 back to because I would never even know what their normal blood pressure is. I just met the guy. But I'm thinking, I get them to my first goal. Okay, great. Look at urine output. I look at skin color. I look at et cetera, other signs of perfusion, cap refill. And, if I'm not really hitting my marks, urine output isn't very good. Cap refill is slow still. I would think you should be tempted to maybe this guy needs a bit more fluid to get him where he needs to be.
I mean, it's not unreasonable, especially if you're hovering around, if you're hovering around your goal, right? And a MAP of 65 is just sort of your minimum accepted number physiologic. So if you're hovering in, low 60s, 65, and they're still not responding, a trial of pushing them to 70 or a trial of giving them more fluid or more blood or turning up your pressure a little bit. I mean, that I would endorse.
Okay. That's more like what I was talking about.
Okay. Yeah. Regardless of whether they were a chronic hypertensive or not, we would try to see if more pressure gave us better recovery.
And part of that, as my thought, is not just the whole idea of don't blow clots, which obviously you don't want to, but from what I understand, at roughly an hour or so, obviously depending, that clot that formed should be stable, unless there's some other extenuating things. But maybe you start pushing, instead of a MAP of, let's say 65, we go to 70, we go to 75. If his blood pressure stays stable and we're good, okay, maybe we go to the next level, and until we get a fully resuscitated patient.
I mean, you were flying in the face of one of my favorite axioms, which is perfection is the enemy of good enough. When it comes to
that's true.
Renal perfusion and kidney function, more likely to let somebody go with a low urine output a little bit longer, because the kidneys can also function, and if they can get supported with dialysis, a lot of times they can recover. And you don't know if somebody's headed for acute liver injury or not, and it's resource intensive. So
yeah, absolutely. I mean, in the setting of shock, having an elevated lactate, I would say, is probably pretty common. Low glucose, probably fairly common. He hasn't eaten for hours.
Well, what'll happen with liver injury is, initially you'll resuscitate them. If you do a good job resuscitating them, their lactate will start going down, within hours. And if you give them some glucose, their glucose will go up and it'll probably stay up. And then you'll have the onset, if you have the onset of acute liver injury at the 12 or 24 hour mark, all of a sudden in your resuscitated patient, you'll your lactate will start going up. And you'll be like, what's going on? His MAP's been 65 for the last 12 hours. Why is his lactate going up? And then his glucose will start going down. And it's like, why is that? His glucose has been 90, 80, and now it's 50. And I've been giving him glucose either on a drip or at the same interval. That's how that'll happen.
No, absolutely makes sense. Well, perfect. Is there anything else I missed, or any other beliefs that you'd like to squish?
Clear as mud, right? It's tough. acute liver injury in a shocky patient is when we see it in a fully staffed university ICU, we sort of look at each other and are like, uh-oh. So it's one of those things that you hope you never have to encounter. And honestly, I'll finish with, we talk about prevention. You ask about prevention. The best prevention for it is recognize shock as early as possible, identify the mechanism correctly, and start treating shock, which is treat the source and resuscitate, provide the appropriate resuscitation as soon as possible. Because as soon as the dose of shock is administered, the inciting event is administered, whether it's trauma, whether it's an infection, whether it's a thermal injury, the faster you recognize it and reverse it, the lower the risk of progressing to shock liver. One of the famous cases I remember was a triathlete, I think he was in a race in South Carolina. It was when I was in medical school, and it was warm, and he was winning the race. I think the first time he was running a race, in his amateur triathlon career. And he was showing signs of struggling on the run. He would go from like water station to water station. He'd be more unsteady. He'd be stumbling. He barely made it across the finish line. He staggered. He fell and then was unconscious. And he died of shock liver. He died of hyperthermic injury. His liver enzymes were off the rails and never came back. And there's one of those things where this had probably been brewing for at least an hour, if not longer. And had he stopped, had it been recognized, had it been intervened on, he probably wouldn't have progressed to that point and would have lived. So there's an analogy of how, and shock is the core of what we do in prolonged field care is the resuscitation, is the recognition and resuscitation of shock when we can't get a patient to definitive care. The first rule of treating shock is early recognition.
Absolutely. Well, thank you, Doug. I really appreciate it.
You're welcome.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.